It's a great pleasure to be able to introduce Brian Eisner to give the very special BAUS Endourology guest lecture. It's a shame that we didn't get to do this in person because Brian is a great character and an excellent speaker, but I'm very much looking forward to watching the video that he's prepared for you entitled Endourology, Not Just Seeing, but Also Believing. Brian has got an amazing grounding as an endoluminal endourologist, like some of us here, educated at Harvard and then at the University of Michigan Medical School, and then going on to do his Stone Fellowship at UCSF with Marshall Stoller, and is now the co-director of the Kidney Stone Program at the Mass General Hospital. So quite an extraordinary pedigree to bring to our BAUS meeting. Brian's widely published, I think over 130 papers that I found, and looking up some of those, they cover the depth and breadth of endourological management, from diagnostics like the comparison of stone size measurement between ultrasound and CT, techniques as part of the endo edge group with the dusting versus the busting, some basic science work on intrarenal pressure monitoring, and then practicalities of post-operative management, like the need for antibiotic use after ureterorhinoscopy and the medical management of stone disease. And in fact, when I looked up one of them, I thought, oh, I recognize that one. And so it turns out, not that I think either of us knew it at the time, that we kind of met in a journal when he wrote this for the BJUI at the end of 2010, with an editorial that then followed, recognizing the good work that he'd done. So what Brian is going to do is he's going to talk about endourology, how it started, how it was about a decade ago, indeed, when that paper was written, and some of his predictions for the future, to talk us through the future of stone surgery, prevention and research. Brian, it's a great pleasure to welcome you to BAUS. We will have the celebratory hydration beer afterwards, but for now, we're all looking forward to hearing your talk, Endourology, Not Just Seeing, but Also Believing.
Well, hello. I wish I was in UK with many of my friends and colleagues and meeting new friends today. But unfortunately, this is being recorded by Zoom. I'm incredibly grateful to the BAUS for this wonderful invitation and this huge honor. I hope that everybody and their families are safe and well. And thank you so much for inviting me to give this lecture entitled Endourology, Not Just Seeing, but Also Believing, a Vision for the Future. And here are my disclosures and conflicts of interest, including editorial board work, consultancy, and also stock equity ownership in startup companies. So this was a text message, a WhatsApp that I got from my good friend, Mr. Darren Smith, last September 2019, or 2 Septembers ago. And he confirmed to me that I was being invited. I was so thrilled and so honored. He asked me if I had any suggestions, and then he suggested the following topic: endourology, not just seeing, but also believing, a vision for future progress. And I was really thrilled at this. This isn't your average, here's why I do PCNLs in the supine position, or here's a review of the guidelines, but rather an opportunity for me and for us to really consider where we've been, where we are, and what is our future. So to open, as I do many times, I like to think of some inspirational quotations. And I think first, perhaps no more appropriate than Sir Isaac Newton, who said, "If I have seen further, it is by standing on the shoulders of giants." I think we all have to recognize where we came from, who trained us, what we've learned, and how we can build upon their incredible work to create the future of endourology and stone disease. And the second quote actually is by both of my mentors. My mentor, Stephen Dreller from residency, who recently passed away, and my mentor, Marshall Stoller from fellowship, who both told me that they learned none of the things that they were teaching me when I was a resident fellow when they were residents. We're in a rapidly progressing field, and we have to keep up with the times, move things forward, but things are changing rapidly, and it's very exciting. So just to give a little summary of what I plan to do, I want to take the approach of learning from the past, living and working in the present, and dreaming of the future. I picked several topics of personal interest and research. It's difficult to give a true comprehensive lecture of all of endourology in 30 minutes, so I needed to pick and choose. And finally, what I tried to think of was game changers and unmet needs. I think what's truly inspiring is that many of our mentors, peers, and friends have already contributed or are contributing to changing the game. And I hope to highlight some of those today. But I always ask myself or challenge myself the question, what are the unmet needs in patient care and how may we address them? I'd like to start where it all began. This is an excerpt from a publication in the Annals of Surgery in June 1937 by Alexander Randall on the origin and growth of renal calculi. And he had 7 conclusions, which I've paraphrased here. The first, renal calculus formation is dependent upon a pre-existing lesion. He expected that the location of that lesion was the renal papilla, which occurs in about 17% of autopsy specimens, and that was out of about 430 that were analyzed. They noted 28 specimens of renal calculus adherent to the papilla, and he also noted that calcium oxalate and calcium phosphate stones grow adherent to the plaque. Plaques appear to be a natural reparative process due to some form of tubule damage. And finally, the bottom quote, the answer to the secret, which has shrouded the mystery of true etiology of primary renal calculus, is sought to be an increasing knowledge of the renal papilla. What you see here is a picture from his publication, and you can see a beautiful calcium oxalate stone. That is the black or dark, very dark part of the stone to the right. And then the white part is the calcium phosphate attachment. And Randall said, the white portion is the torn out plaque from which the stone developed, composed of calcium carbonate and calcium phosphate. And this was really the first, one of the first studies and hypotheses of where stones come from. Very, very impressive work. This is just another image from his paper, a colored photomicrograph of papillary stone attached to calcium plaque. The stone is composed of calcium phosphate. So again, this is where it all started. Alexander Randall observing that perhaps the key to stone formation lie within the plaque and the papilla. So where are we in the present? Well, many people have certainly done work in this field, but I think that this group, Dr. Lingemann, Dr. Coe, and colleagues have certainly made one of the greatest contributions to understanding of plaque physiology and stone formation. This is one of their studies published in 2015. And in this study, they defined 4 different pathways for stone formation. 1, calcium oxalate stone growth over sites of Randall's plaque. And here you can see calcium oxalate stone with surrounding plaque in the picture on the left. In the B picture on the right, you see as the stone is removed, the small white area demarcated by an asterisk, which is a calcium phosphate nidus where it was growing attached to the papilla. The second mechanism is overgrowths on the ends of the Bellini duct plugs. This is noted in most stone subtypes, as opposed to Randall's plaque, which is noted primarily in patients with hypercalciuria. What you see in the picture on the right, the asterisk shows an overgrowth on the plugged Bellini duct. Arrows show depressions near the papillary tip, which are often seen in stone compositions other than calcium oxalate. And finally, arrowhead showing some Randall's plaque. A third mechanism for stone formation is microlith formation within the lumens of the dilated intermedullary collecting ducts. And this is seen in patients with cystinuria. What you see on the left-hand side in figure A is a dilated collecting duct. And when they lasered it, you see a stone popping out, a stone hiding within and growing within the medullary collecting duct. And finally, they've also noted the 4th type of mechanism, which is that cystine stones can also form in free solution. So a lot of advances in the field by this group, really trying to define the mechanisms of stone formation for calcium and non-calcium stone formers. So what are the unmet needs in this field? Well, do we really understand the pathophysiology? Do we understand the mechanisms of stone formation? And do we understand factors outside the 24-hour urine that may promote and prevent stone formation? Now, I want to talk a little bit about the future, and I'm going to call this part Digging Deeper, and I'm going to credit my mentor, Marshall Stoller, and his group for some of the most incredible and exciting work, I think, in the last few years, and much more to come. They hypothesized that nephrocalcinosis begins with a calcium phosphate deposit at the tip of the medullopapillary complex, which is called Randall's plaque, consistent with prior studies. But they asked the question, and this is provocative, are Randall's plaques the end game, or are they the origins of stones? Previously, we've all thought they were the origins of stones, but perhaps they're the end game. And is the primary stone formation event a pathology proximal to the renal papilla? This is part of their publication where they have a high resolution ex vivo micro CT. And here what you can see, and I will highlight it here with my mouse, is you see the stone here and you see Randall's plaque here. But when you see the studies of the renal papilla, which is in this area right here, you see that deep into the renal papilla, there's a lot of pathophysiology or pathology, as well as biomineralization. There is significant mineralization of the renal parenchyma proximal to the renal papilla. And you can see that this mineralization occurs with different morphologies in different places. Here we see intratubular, and here we see interstitial mineral formations. We can also see that the Stoller's group described varying volumes of medullopapillary complex deposits in the papillae with and without Randall's plaques. So on the far left, you can see a patient who's Randall plaque negative, and you can see very, very little deposit. In the middle and on the right side, you can see a continuum of increasing Randall plaque formation. And again, you can see the various different deposits, the various different locations, all proximal to the tip of the renal papilla. When they study this further with scanning electron microscopy and other microscopic techniques, what they note is that intratubular minerals show plate-like configurations and demonstrate association with collagen fibrils, whereas interstitial minerals are spherical and demonstrate concentric ring-like structures. Not all renal biomineral deposits are the same, and the diversity of the deposits and changes they induce on tubular flow may lead to downstream plaque formation. So some thoughts and conclusions on digging deeper into the formation of stones and the future of this field. It appears that proximal intertubular biomineral deposits are associated with Randall plaque formation. Plaque formation may be a downstream event, as opposed to the inciting event in stone formation as previously thought. The architecture of the medullopapillary complex at proximal and distal portions varies markedly, and perhaps future research designed at understanding the on-off switch for these mineralizations may better help us understand the mechanisms of stone formation. I'm now going to shift gears a little bit and talk about some surgical techniques or procedural techniques, and we'll start, of course, with shockwave lithotripsy. This is one of the original publications by Chaucy and his group, shockwave lithotripsy, and it was published in 1982 in the Journal of Urology. 72 patients treated, 63 with follow-up. They called this extracorporeal, and perhaps using a term very familiar to us today, contact-free destruction of stones using shockwaves. 14 patients had general anesthesia and 58 had peridural anesthesia. An imaging follow-up was plain radiography. They noted 5 patients with residual stones, mostly in lower pole calyces. 80% of patients were spared what that time was a very much more invasive open stone surgery. And of course, this technology helped usher in the era of minimally invasive stone surgery. I had the privilege of actually interviewing Dr. Chaucy with Dr. Dretler on a book chapter we wrote of Innovation of Stone Disease. One of the most interesting things that Dr. Chaucy stated was that his initial abstract was rejected from the AUA meeting. It was accepted 1 year later. There was other resistance to publishing the original results of shockwave lithotripsy, as the first paper from the US did not appear until 2 years after the initial study of the initial patients were treated. 10 years after the first patient was treated in Munich, the authors were presented with the Distinguished Contribution Award by the AUA. And this inspired my mentor, Steve Dretler, to note that the most innovative ideas are often rejected from journals on their first submission. Something to think about for those of us who are trying to innovate. So what is the presence of shockwave lithotripsy? Well, we know there are various techniques that have been described to optimize shockwave lithotripsy. I'm going to cover a few. The first is optimizing success. This is a randomized controlled trial of 220 patients examining shockwave rate. And what the authors know from Ken Pace and John Honey's groups are that slower shockwave rates are associated with improved overall success, and the greatest improvements were noted for the largest stones. When we want to discuss minimizing trauma from the shockwaves, this is Dr. Lingham and Dr. Evans' group, and they've experimented in pigs with various voltage and shockwave protocols in order to minimize trauma. What they know to one of their recent studies is that a pre-treatment with 500 shockwaves at the lowest dose resulted in the least amount of renal trauma. And this regimen had similar results to previously published studies from their group that included a 3-minute pause. So at this time, at least in the States, we're very comfortable with 500 shocks at the lowest dose before ramping up and omitting the pause in an effort to minimize trauma from shockwave lithotripsy. How do we predict success of shockwave lithotripsy, and how do we counsel our patients? This is a very nice study by Dr. Guillaume Parikh and his group from Brown. And what they did was they defined the triple D score. They note that the 3 Ds are Hounsfield density, stone to skin distance, and stone ellipsoid volume, or diameter, if it's easier to remember this way. They evaluated 133 patients and had a 57% stone-free rate. And of course, when I look at that stone-free rate, I would say that's mediocre. And I would say that many of my patients would not accept the treatment with that stone-free rate. But I think what's really incredible about this work is that they've created a simple score which can help predict who may have a higher stone-free rate and who may have less. And what they note, as you see in the graph on the right, is that the triple D scores of 0, 1, and 2, 3, from unfavorable to favorable, predict success of shock wave lithotripsy. So if all parameters for the triple D score are favorable, then the shock wave lithotripsy success rates are over 90%. If several are favorable, they're close to 80%. But once we get into the scores of 0 and 1, we see that the stone-free rate dips below 50%. I find this incredibly useful because I do use it to counsel patients. And of course, in our eras of patient satisfaction importance and patient-reported outcomes, of course, it's highly important to consider the patient's needs and desires and the patient's goals for surgery or procedures when we're helping them choose the correct treatment for their stone disease. And yet, despite all these things, shock wave lithotripsy is on the decline. We see that from 1991 to 2010, shock wave lithotripsy went from 70% of all stone treatments in Ontario, Canada, to 35% of all stone treatments in a study of an administrative database by Ken Pace's group. What we see also in the same time period is concomitantly ureteroscopy, likely due to improvements in technique and instrumentation, has increased and basically overtaken shock wave lithotripsy as the most important treatment, or sorry, the most common treatment for ureteral stones in their area. So what are the unmet needs? I would argue the unmet needs include a shock wave lithotripsy efficacy that can match stone-free rates of modern ureteroscopy, greater predictability in shock wave lithotripsy success, and perhaps portability of shock wave machines and moving to an office-based procedure. Now, I want to review a new kind of lithotripsy, and I do want to declare a conflict of interest, which is that I'm an advisor to the company that's manufacturing this device. As we may know, shock wave lithotripsy is brief, high-amplitude acoustic shocks, which are used to break a stone. They fracture the stone into larger pieces, and continued treatment hopefully fractures these pieces into smaller fragments. Burst wave lithotripsy, a new technique, is low-amplitude bursts of ultrasound delivered at higher frequencies to cyclically stress stones until fracture. It fractures stones into smaller pieces of a consistent size, which should result theoretically in less trauma to the kidney and perhaps less pain for the patients. Now, I acknowledge the work of Matt Sorensen's group and his collaborators at the University of Washington for really incredible engineering and really trailblazing in this field. This is their first in vitro study, or one of the early in vitro studies, which I think is quite impressive. What we see here is stones of various compositions, including their fragmentation times and their results. I'd like to draw your attention first to the very, very low fragmentation times. You see that, the typical shock wave lithotripsy treatment, which can be 20 to 30 minutes, these stones, again, in vitro, but were fractured in quite a short amount of time, 1 minute, 2 minutes, 15 minutes, and 20 minutes. I think the other thing to know is that this treatment can also appears to be able to be used for cystine stones. So we train our trainees, certainly in the US, fairly dogmatically that performing shock wave lithotripsy on cystine stones tends to be a losing effort. We feel that they're many, many times more resistant to shock waves than calcium oxalate stones, and so we rarely perform shock wave in these patients. But you see here in the photograph marked D, a cystine stone that in under 21 minutes was powderized. So very promising technology in terms of efficiency and the ability to fracture all stones. So here are my thoughts on the future of non-invasive lithotripsy. This burst wave lithotripsy could be useful, perhaps for office treatment of renal and ureteral stones. Is it less painful? Could it be done awake? It appears in vitro studies to perhaps approach and defeat the efficiency of shock wave lithotripsy, but obviously human studies are needed. Perhaps more consistent, smaller post-procedural fragments will lead to less colic after lithotripsy compared to shockwave. Perhaps there'll be less trauma. And of course, we all would welcome the ability to treat all stone types, including cystine stones. And I do want to note that first-in-human studies are underway in the United States with this technology, and I'm really excited and looking forward to their results. I want to turn briefly now to laser technology in ureteroscopy. And I want to notice two studies here, both published in the early 80s. One came out of UK exclusively, that's Watson and Wickham. And one came out of collaborative work by my mentor, Steve Dretler, as well as Graham Watson. Each of these studies had 32 and 17 patients respectively, and they used a 250 micron laser fiber with the pulse dye laser. What they both noticed was that there was a significant advantage of this technology over the other probes that are used to break stones at that time, which were electrohydraulic lithotripsy, ballistic lithotripsy, and ultrasonic lithotripsy. They noted effectiveness of the laser. And interestingly, they noted that they were able to break stones into tiny particles with spontaneous passable fragments. This is the initial description of laser lithotripsy in the early 80s. And also I want to note, is it the initial description of dusting? As you see, the authors intended to break up stones into very, very tiny particles that would spontaneously pass. So what about the present? Well, I would say over the past 5 years, the MOSES technology has gained a lot of press and certainly study. This is a technology that divides the holmium laser pulse into two adjacent peaks. The first peak separates fluid ahead of the stone, which is called the MOSES effect. The second peak precisely delivers the energy towards the stone. It should result in less energy lost, and the laser transmission is less dependent on the fiber to stone distance. The theoretical advantages include stone fragmentation improvement and decrease in mobility and stone retropulsion. And I'm going to reference a study recently published by Sierra Andonian's group from Canada. So this is a prospective double-blind randomized controlled trial with 36 patients per arm, MOSES versus non-MOSES. And what they found was that the MOSES mode was associated with significant decreases in fragmentation and pulverization time, significant decreases in procedure time, significant decreases in stone retropulsion, and no differences in complications or stone-free rates. So my studies, as we think about the present, or my thoughts, excuse me, is that this is an impressive double-blind randomized controlled trial design. The authors report significant differences, including a 20% reduction in OR time, and other holmium laser manufacturers are now creating similar technologies, presumably to compete. But my questions are, why is the MOSES technology not used universally? Is it due to cost? Is it due to the fact that surgeons are not convinced of its efficacy? Is it due to the fact that non-MOSES lasers are effective enough? I think another thing to think about when we think about the present is that I think many people feel that given high rates of residual stone fragments after ureteroscopy, perhaps we're not in an optimal state right now in terms of our treatment. So this is a prospective evaluation by Peggy Pearl's group, Jody Antonelli, Noah Canvasser from University of Texas Southwestern, where they performed aggressive basketing for ureteroscopy, where every attempt was made to extract all stone fragments, regardless of size. They treated 104 patients in 141 renal units, and their overall stone-free rate was 55%. They had a mean of almost 40 to 50 passes with an estimated 30 seconds per basket pass. And so my thoughts are 20 plus minutes of basketing per case still resulted in suboptimal stone-free rates. Not just my opinion, also noted by the authors. And so even in the hands of experts, many patients are not stone-free after ureteroscopy. This is the present. I think this is perhaps as good as it can be with current technologies, but the question is, what is the next frontier? I would argue that the unmet needs in laser technology include improved performance for more efficient stone treatment, improved stone-free rates after ureteroscopy, decreasing stone extractions and increasing stone extraction efficiency. And then my question is, will better performing lasers shift some PCNL treatment to less invasive, less risky ureteroscopy? So I ask myself a question. You notice there's a question mark next to the future here. And I want to talk about the thulium laser fiber. So you see here comparisons. Many people are very aware of this, but I want to bring your attention to, in this discussion by Dr. Traxair, of some characteristics of the superpulse thulium laser fiber that are a bit unique. You'll see here that the first is that the frequency, the potential frequency is far greater than the highest frequency achieved by holmium lasers. So currently, the holmium lasers can achieve frequencies of about 100 or 120 hertz, whereas the superpulse thulium fiber can achieve frequencies of 2000 hertz. A second characteristic I want to bring to your attention is the size of the laser fiber. And the superpulse thulium laser fiber can be significantly smaller than standardly used holmium YAG laser fibers. There is early and initial experience with these lasers, but not robust experience to date, I would argue. I'm intrigued, but I'm not convinced. My personal experience is 25 cases in a short trial with the superpulse thulium laser fiber. And here are some thoughts. I would ask, what are the advantages of parameters not achievable by the Holmium laser? So I am intrigued by using parameters like 0.025 joules and 750 hertz. But will that create better dust? And of course, the biggest question, will that create better outcomes? Will a smaller fiber enable improved ureteroscopic treatment of lower pole stones? And will that fiber have enough stability to be useful while working in the working channel of a ureteroscope? So I think that there are some potential theoretical advantages to the superpulsed thulium. I think a lot of people are interested in trying it, but I'm interested in understanding where those advantages take us in the future of laser lithotripsy. And I think the jury is still out. I want to talk a little bit about pharmacological relaxation of the ureter at this point and some scientific work that I'm very excited to present from our group. So here's the past. You have a ureteral stone, try and pass it. It may take a month. This is Chris Kane's paper, 75 patients with ureteral calculi. 16 patients had stones greater than 4 millimeters. Half of them required intervention, and the average time to pass was 22 days. This paper was published in 1999. And of course, and not surprisingly, they noted that intervention rate increases as stone size increases. This was the standard of care in 1999. We hope you pass your stone, otherwise you're going to require ureteroscopy or shockwave. The more recent past, should we give alpha blockers to all? This is a well-known study, especially in UK. John Hollingsworth's study of a meta-analysis of 9 studies, the original studies on calcium channel blockers and alpha blockers for expulsion of ureteral stones. And of course, what they noticed and what they described in their meta-analysis was that patients given alpha or calcium channel blockers had a significantly increased likelihood of passing a stone. And the number needed to treat was 4. We move now to a landmark study, the SUSPEND trial performed in the UK, a randomized controlled trial of adults ages 18 to 65 with over 1,100 participants. And the groups included tamsulosin, nifedipine, and placebo. These are new results for the present. What this study showed is that nifedipine and tamsulosin did not increase the likelihood of stone passage over 4 weeks, and the use of these drugs was unlikely to be cost effective. This was a very significant finding. Of course, many people in the audience are well aware of this because it really challenged the dogma that alpha blockers should be used routinely for ureteral stones. And of course, interesting and recent provocative data that alpha blockers may decrease insertion forces necessary to place ureteral access sheath. But I think the science of this and the study of this is still needs a bit of further work. This was a small study which did note that alpha blockers may be beneficial, but still with a 10% ureteral injury and lesion rate with placement of ureteral access sheaths. So I would argue that in this case, the unmet needs are more potent relaxation of the ureter. Alpha blockers are of questionable value for stone passage. Can we minimize trauma due to access sheath and ureteroscope placement while increasing successive placement of these devices? So I'd like to share with you a study that I've been honored to participate in with some really fascinating collaborators from MIT, notably Michael Seema, our senior author, and Chris Lee, who wrote his PhD on this work. We performed a multifaceted study to identify optimal topical therapy. So as in a therapy applied to the ureter through a ureteral catheter for ureteral relaxation. We use human ureteral smooth muscle cell culture contraction assays to identify target drugs. We used ex vivo porcine experiments to measure ureteral contractions, and finally live pig experiments to measure ureteral contractions. And these included placebo versus oral tamsulosin versus topical therapy. Here is our high throughput screening assay using cell culture of human ureteral smooth muscle. And what we noted was that tamsulosin, topical tamsulosin, has a minimal effect. In the upper set of photos, what you see is that the green denotes cells in their contracted state. You see on the far left, the cells are in their contracted state with control. And you see that on picture F on the top, that with tamsulosin, there's still quite a bit of green staining. That's also represented graphically in figure C below. What we also noted was that nifedipine and Rho kinase inhibitors demonstrated significant ureteral relaxation properties as denoted by the absence of green staining in the figures G and H, and you see the graphs of the cell contractions in figures A and B from below. So suffice it to say that in terms of topical therapy, that nifedipine and Rho kinase had a significantly greater effect than tamsulosin, which was very similar to control. When we look at drug synergy, we also note that the combination of nifedipine and Rho kinase caused optimal relaxation. And you see here that we're able to relax 72% of cells in cell culture with the combination, whereas only about 44 to 49%. I recall studying synergy of antibiotics when I was in medical school, and I liken this effect to that both drugs in combination have a far greater effect than either drug as an individual, even at maximum doses. I'm now going to show our live pig data. These are what you can see on the graphs on top are using an acoustic probe to measure intraluminal ureteral pressures and convert that to studies of ureteral contractions. What you see is on the left is the standard baseline ureteral contraction rate in terms of amplitude and frequency for a live pig. What you see in the middle is the amplitude and frequency of contractions with the pig having taken tamsulosin. And then what you see on the right is a near complete obliteration of the amplitude and a significant drop in the frequency given our topical therapy of nifedipine plus urokinase inhibitor. So we do know that tamsulosin works, but it doesn't work that well. It results in a 50% reduction of amplitude and no reduction in frequency. Here is why we think there's significant advantage of topical therapy. We noted that urokinase inhibitor plus nifedipine, when delivered topically, resulted in a 90% reduction in contraction amplitude and a 50% reduction in frequency. And not only that, but the timing of onset was 90 seconds with no systemic absorption of drug. So we feel this is provocative. We feel that we may have an understanding of why tamsulosin has been shown to be efficacious in some studies, but not in others, and why perhaps topical therapy is the key. Because not being limited by the systemic effects of oral therapy, we can deliver massive doses of nifedipine and urokinase or other drugs to the ureter topically and significantly impair or halt the contractions. I want to briefly finish my talk by discussing research in the future of data collection. So this is a study. I know Peggy Pearl is one of our other distinguished speakers, and also, of course, one of my heroes and great colleagues at Endourology. This is a randomized controlled trial, which I commend her and her co-authors on, of 42 patients, deciding whether we should place a stent or nephrostomy for patients who come in with infection and ureteral stone. They showed no difference in outcomes, but PCN was less costly. And they said the decision of which mode of drainage to use may be based on logistical factors, surgeon preference, and stone characteristics. While I, of course, commend Peggy and her group for running a randomized controlled trial, we see here what the challenges are. Small sample size, data is difficult to collect and enroll, and despite having consecutive patients over a 2-year period, they were only able to enroll 42 patients. They made no true definitive recommendations based on the results and left the decision up to the surgeons. So this was an excellent first step, but I think the field may still need more in order to make definitive decisions. I would argue the present has seen the popularization of healthcare claims data. So this is a claims database, the nationwide inpatient sample over a 10-year period in a study by Kwok Trin and his group, an analysis of 400,000 patients hospitalized with infected stones. What they noted was that nephrostomy utilization decreased over the study period, and that nephrostomy showed higher rates of sepsis, longer length of stay, and higher mortality compared with stent. But the authors do note many weaknesses of the observational data, including that observational data preclude the assessment of timing between outcome and intervention and disease severity. Are these results believable, or are they due to bias and confounders of the study design? So what are the unmet needs? Well, the problem is that large data sets for analysis reflect local and regional practices are absent, and the ability to abstract complete medical records from the currently large claim sets doesn't exist. We need the ability to design large data sets which answer specific research questions as opposed to using data sets created for other purposes. I'd briefly like to touch upon a project that I'm undertaking currently with one of my residents, Gordon Liu, about machine learning. Now, the traditional approach to big data is to use model and data and input the model and data, get some computation, and then report the results. And what machine learning does is it inputs data, and the machine learns and the machine understands. And that is by us teaching the machine. And I'll show you in some future slides. And then we can create a predictive model. And so what you see is that we're going to use the data to create the model as opposed to invent a model to create the data. We wanted to undertake a study identifying factors or combination of factors that predict ureteral stone passage. The cohort is patients who present to an emergency room with a symptomatic ureteral stone, and the outcomes are spontaneous stone passes versus intervention. So the first task is defining the patient population and teaching the computer how to search for and identify appropriate patients. We had to review CT scans to define common phrases for identification of ureteral stone presence or absence. So for several weeks, we reviewed many different CT scans to come up with all the free text language, all the different free text language parameters that the radiologists use. These include things like obstructing stone at the ureterovesical junction, obstructing stones with upstream hydronephrosis, and many more. And then we had to write code, computer code, to search free text databases in the electronic medical record to identify appropriate patients. So in other words, we have created code based on common phrases so that we can create a massive search to identify patients. The second task was to identify that the patient identification programming works. So we audited our study with 103 CT and ultrasound reports positive for stone and 101 CT ultrasound reports negative for stone. We developed the set with machine learning and then had a 50% test set. And what you can see is that based on what we noted, our code at the bottom has a positive predictive value of 97% and a negative predictive value of 91. And so we were very comfortable with this, that we have taught the machine based on our studies and based on our coding to identify these patients with stones on their CT scans and also to differentiate patients with and without stones. With this coding and with this programming, we identified almost 90,000 patients in our system. Our parent company, Partners Healthcare, owns about 10 hospitals. Some are high volume, some are smaller volume, but we're able to identify a massive data set. And now comes the machine learning part and the future. So what we're going to do is we split the data now that we have patients with confirmed stones. We will train the machine by helping the machine understand what happens to these patients. So we'll help the machine understand, or the computers understand, the patients that get intervention and the patients that don't get intervention. At the same time, we'll also account for loss to follow-up. Once we train the machine to be able to differentiate these patients, we'll include the demographics, vitals, medical and surgical history, medications, labs, and imaging, and other things that may go into predicting stone passage versus need for intervention. We'll then prospectively validate this, and this is the big test. Can we train the machine based on our modeling and based on our identification of patients to then identify patients in the future who will or will not need intervention so that we can better counsel our patients? So the summary is that training the machine enables identification of the correct patients. Unlike claims data, any variable of interest which is captured in the EMR can be included. We can create more realistic regression models, algorithms, and nomograms based on real-world data. This is relevant to local patients and practice patterns. It addresses confounders and biases that are inherent in studies using claims data. It can guide medical decision-making in the future, and it can be used for studies with a smaller N in order to increase study population. Example, things like complications of PCNL, or perhaps extracting data from a 10 hospital-wide system or a national health system may be more useful than from a single hospital. So I want to summarize this talk. I apologize for the whirlwind, but I wanted to make sure this was interesting and covered several topics. I could not be more grateful for this great honor and for the invitation to participate in this meeting. I want to summarize by saying stone disease and endourology are places of great innovation. Philosophy is learn from the past, optimize in the present, and innovate for the future. And I hope these examples and evolutions may inspire each of us to think about our own journeys and how innovation may create radical change to improve the future care of stone patients. So I want to thank you. I'm certainly open to chatting with anyone about these topics or anything else in stone disease or endourology. I want to show some pictures of some of my great friends, many of whom may be at this meeting, that I spent some time with at the Royal Society of Medicine last year in 2019. And of course, acknowledge the love and support of my beautiful family, including my wife and 3 children. Thank you very much for this wonderful opportunity. It's an incredible honor, and I look forward to witnessing the rest of this amazing meeting.